First of all, it is my great pleasure and honor to be here. Thank you for inviting me and giving me this opportunity. So I have been amazed by this enthusiasm for immunotherapy in Thailand, and also amazed by your hospitality since I arrived here. Thank you very much. And my name is Haruko Tashiro from Teikyo University. My specialty is adult hem-onc, especially leukemia. So I have been working on this C-type lectin-like molecule 1, CLL-1 CAR for AML therapy. So today I'm going to talk about the current situation of AML CAR T-cell therapy and my CLL-1 CAR project. So here is my disclosure. So since I'm a hem-onc physician, so I'm going to start from the current situation of AML therapy in Japan. Some of you must be physicians, right? So then we treat AML fit patients with 7+3 chemotherapy regimen, probably same as you guys do. And if patients have standard or higher risk AML, according to ELN criteria, we perform allogeneic stem cell transplantation. So here is the data from Japanese registry. In Japan, around 1,400 allo-SCT were performed annually for AML. So although some patients can get cured by SCT, but some can't. So this is the overall survival of AML patients who received allogeneic SCT from HLA identical sibling donor. So that survival probabilities at 5 years after transplantation are 62.1% in the standard risk and 27.2% in the advanced risk group. So especially for the advanced risk, there is a need for better therapy. So we need something like CAR T-cell therapy for AML. So as we all know, CD19 CAR has shown the great success against B-cell malignancies and BCMA CAR for multiple myeloma maybe. However, this result hasn't been really translated to AML yet. So one of the reasons is that many AML antigens are also expressed by normal hematopoietic stem cells. So CD19 CAR kill normal B cells and the patients would develop B-cell aplasia, but normally, which is acceptable. But if the CAR can eliminate hematopoietic stem progenitor cells, that would not be acceptable. So also, AML is a genomically heterogeneous disease. This is so it might be difficult to target one, to have one target, one antigen for target. So several AML CAR have shown toxicity against normal marrow progenitors. Eventually, patients need HSCTs or the transient CAR expression system, like yesterday I presented, the mRNA CAR is necessary. So no optimal CAR has not been established for AML yet. So let's review the current status on AML CAR T clinical trials. In 2010, an Australian group started Louis Y. CAR trial for several malignancies, including AML. So it showed some efficacy, but obviously that wasn't great. Since then, many groups have tried to show the efficacy for AML. And as of today, over 40 trials of AML CAR T are ongoing in the world. So compared to ALL, which has more than 900 trials, this number is quite low. And as the target antigen, CD123, CD33, CLL-1, CD7, and FLAT3. And yeah, in Japan, so we have GMR as well. And so some trials are targeting the multiple antigens. And as you can see, these trials are mostly run in China or US. Since I'm going to talk about my CLL-1 CAR stuff today, let's summarize CLL-1 clinical trials. So all published trials are from China. The above two are from the same institution. So they treated pediatric relapse refractory AML with their ICAS9, CLL-1 CD28, 27 zeta. And they treated 4 patients and 3 achieved MRD negative CR, which was pretty good. Then they also treated 8 pediatric AML patients with different CLL-1 CAR, and 6 patients achieved CR or CRI. However, all patients developed severe pancytopenia. And this is from different group. They treated adult relapse refractory AML, and 7 out of 10 achieved CR or CRI. But also they developed the pancytopenia. So the last group updated their clinical trial at the ASH 2023, which is coming, and the abstract is just opened. Then now they have 30 patients. They treated 30 patients. Then overall response rate was 73.3%, pretty good. But most of the patients showed the severe cytopenia. So 19 patients received SCT after infusion. The median time to SCT is 0.7 months. So although they said there is no dose-limiting toxicity, I was wondering why these high-dose group died earlier. So they didn't discuss, at least in the abstract. So then they conclude that CLL-1 CAR may have the opportunity to achieve CR or CRI prior to transplantation, which may reduce the risk of relapse and mortality and prolong patient survival. So for now, we still need SCT after CLL-1 CAR T. So let's go back to 2014 when I started to work on CLL-1 CAR. So at that time, AML CAR wasn't as hot as CD19 CAR. So my boss just asked me if I want to make something new CAR for AML. So he didn't say I should use this antigen or that antigen. He just told me, oh, let's make a new CAR for AML. Then I decided to make this CLL-1 CAR. So CLL-1 is a type 2 membrane glycoprotein, which is expressed on myeloid cells, AML blast, and leukemic stem cells. So importantly, normal hematopoietic stem cells do not express CLL-1. So this is mixing data from my old lab in US and current lab in Japan. So I have tested the CLL-1 expression on primary AML patient sample. And in both cohort, US and Japanese cohort showed the CLL-1 positive population a lot. Looks like Japanese cohort has more heterogeneity. I don't know why. So this is the HL60, which I have used most of my experiment as a CLL-1 positive target. So this is my in vivo setting. So I irradiated mice, and then next day infused the tumor cells, 50,000, which is pretty low, but HL60 grow pretty quickly. So I have decided to go with this low number. Then injected 0.6 million T cells. Then without any treatment or CLL-1 delta, just control CAR, tumor leukemia grow pretty quickly. But with CLL-1 delta, tumor cells were controlled, and that improved the mouse survival. So CLL-1 CAR worked. Then to test the influence to normal hematopoietic cells, we performed the colony forming assay. Then, so I mixed this cord blood and CLL-1 CAR or CLL-1 delta, the control CAR, then for 5 hours. Then put that mixture into this mesocult media, which has these growth factor. Then after 14 days, counted these colonies. Then expectedly, there was no significant decrease of erythroid monocytic and granulocytic colonies by CLL-1 BB zeta. So CLL-1 BB zeta did not inhibit the colony formation, which was good. However, so since normal mature myeloid cells also express CLL-1, so this is monocyte and they do express quite a high level of CLL-1. So I have tested if the CLL-1 CAR kill monocyte. Then kind of expectedly, this CLL-1 CAR killed their own like autologous monocyte. So then at that time, I just decided to introduce suicide system. So I used the ICASpace9 and transduced the ICASpace9 into that CLL-1 CAR. Then just decided to eliminate this CLL-1 CAR after they finished their work. So here is the interim summary. CLL-1 CAR T targets AML blasts and leukemic stem cells without inhibiting colony formation from cold blood progenitors. CLL-1 CAR T showed modest long-term anti-tumor activity in a xenograft mouse model. The introduction of ICAS9 suicide gene system allows controlling the extent of tumor toxicity by the CLL-1 CAR T. So what we need to improve CLL-1 CAR T? So we need to reduce on-target of tumor toxicity, and we need to increase efficacy. The first one is more tricky. So this is a quite difficult problem to deal with. And actually, so the Dr. Michel Sadeline from Memorial Sloan Kettering has been working on this problem. And some of you may know this paper, but recently his group has published this in Cancer Cell. So he has been using this CCR, chimeric co-stimulatory receptor system. So we have been talking about CAR, so which has zeta signal and it can kill the tumor cells, but this CCR doesn't have zeta signal. So, and he chose CREC12A, which is the same molecule as CLL-1. So his CCR targets CREC12A, but this is just this will cause just co-stimulatory signal. And he has this ADGRE2, which is one of the leukemia AML antigen and expressing on the many leukemia blasts at the different level. So some leukemia just express very low level and some are pretty high. And hematopoietic stem progenitor cells express very low level of ADGRE2. Then his ADGRE2 CAR can kill more than HSPC level expressing ADGRE2 expressing some more than HSPC level. So then, so his CAR cannot kill this lower ADGRE2 expressing tumor cells by itself. But with this CREC12A CCR, these population will be targeted by this system. And now he has the CAR with CCR, which can spare mature myeloid. So mature myeloid cells don't express ADGRE2. So then they can spare here and spare here, but can kill most of the leukemia cells. So he made this system. So this is pretty promising. And I, as a physician, I am very hoping this will work. Then many patients, many AML patients can get these effective treatment. However, as a scientist, I needed to work on something, some problem. So I decided to deal with this, like, looked easier problem for me. So then I decided to improve this CLL-1 CAR efficacy. So, and we have already learned, so CAR T-cells need 3 signals, just like TCR signal and co-stimulatory signal, then cytokine signal, signal 3. Then after I left my US lab, other lab members has also decided to improve this CLL-1 CAR. And they used this IL-15. So they introduced the IL-15 into the CLL-1 CAR. Then expected this will improve the outcome. And they used the PDX model, then injected CLL-1 CAR T or CLL-1 CAR T with IL-15. However, unexpectedly, these IL-15 group died much, much earlier. So that was a pretty shocking result. Then these are not from tumor. Then these are from toxicity. And they have figured out why was that. And actually these mice had quite a lot of TNF-alpha in their blood. So then they decided to use anti-TNF-alpha antibody. So injected CAR T-cells, then used these anti-TNF-alpha antibody. Then after tumor cells are eliminated, they eliminated the CAR T-cells. And they were able to show this nice survival curve. But this is not we really wanted, right? So then meantime in Japan, I decided to use a different system. So they used IL-15. So I used this C7R. So I can never say constitutive. So constitutive signaling from an engineered IL-7 receptor. So this is invented by Dr. Thomas Schum from Baylor College of Medicine at that time. So IL-7 receptor has so normally if the IL-7 binds this receptor, the dimerization happened, then the signal will occur. But so this C7R has disulfide bond, and it's always the signal is occurring. And with this C7R, so he used GD2 CAR, and with this C7R, he was able to show the much better tumor control and survival. Now C7R GD2 CAR T is actually being evaluated in clinical trial in US. So this is Dr. Villaroma from CAGT. He kindly gave me these slides. And so the target disease are diffuse midline glioma or other GD2 expressing CNS tumor. So, so these are dose level 0. They treated 3 patients, and all patients showed some improvement, but disease progressed quickly, and all patients died. Then at the dose level 1, they injected 10 million per square C7R GD2 CAR. Then all patients showed some efficacy. And the dose level 2, now they have 30 million per square C7R GD2 CAR. And 5 out of 6 patients showed some response. And 1 patient didn't show the response. However, this patient was found to be actually GD2 negative later. So this is one of the example from the one of the case from the dose level 2. She was 15 years old female with DMG. Then she had these neurological symptoms. And after day 16, her symptoms were improved. And the MRI got better. Eventually, the disease progressed and she died. However, these are pretty promising results. And so there is another C7R trial which is run in China. So they use the C7R CD7 CAR T for relapse refractory TALL. And they treated 11 patients and 12 patients, and 11 got CR. Then no ICANS and manageable CRS. This was also looked promising. Then with these encouraging results, I was hoping C7R CLL-1 CAR performed better than CLL-1 CAR alone. So originally I had these two different constructs, but now I have the one construct. And C7R CLL-1 showed baseline phosphostat 5. So these are without any cytokines. And when I culture CLL-1 CAR T or C7R CLL-1 CAR or non-transduced cells, so even CAR without any cytokine or without any antigen, they don't proliferate. They just like shrink. However, this C7R red line, so they do expand without any cytokine or without any stimulation, at least for 2 weeks. Then they didn't get crazy, so they are like shrinking later. So, but this causes like better persistence. And I was wondering if C7R showed more differentiated phenotype, but there was no difference of phenotype between C7R CAR and CLL-1 CAR. Then I performed the serial co-culture assay. So I added the same number of tumor cells every 3 days. So this is CLL-1 CAR, this is C7R. Then tumor will come here. So first round, second round, both can eliminate the tumor cells. However, third round, the CLL-1 CAR failed to eliminate these tumor cells, but the C7R can still work. And these are tumor cells, and these are T cells. So then I asked if C7R increase hematological toxicity of CLL-1 CAR T, because CLL-1 CAR, so you may remember CLL-1 CAR did not inhibit colony formation. I was expecting with C7R shouldn't cause any colony formation inhibition. Then I did the same thing. However, so in my talk there are so many however, but however, actually this C7R CLL-1 had significantly fewer number of colonies. Then I realized that actually the plate looked different, and so I harvested that media and ran the flow. Actually, in C7R CLL-1 plates, there were so many T cells left, and in other plates, I didn't see any. So I don't know. I have not known if the C7R CLL-1 killed the progenitor or stem cells, or it's just a competing thing. Since T cells expanded a lot, so the stem progenitor didn't have enough chance to expand or differentiate. So then I did the in vivo experiment. So this time I used the same HL60 and at the same tumor number. Then this time I waited for 3 days, then injected fewer number of T cells than the last experiment because I wanted to see the difference. So if I use the same condition, there may not be any difference. So then The result looked a little bit messy, but so CLL-1, C7R CLL-1 CAR T showed much better tumor control, looks like. Again, however, these mice, actually C7R CLL-1 group died, some mice died earlier. Then, so these are not from tumor, and I found, so these mice have the quite a high number of T cells in their blood, and this could be due to high TNF alpha, as same as the IL-15 experiment. I have not tested the ELISA or multiplex or something, but I will check it. So in conclusion, C7R enhanced CLL-1 CAR T proliferation and persistence in vitro culture without any cytokines, and C7R enhanced the anti-tumor efficacy in a serial co-culture assay. And C7R CLL-1 CAR T suppressed colony formation from normal hematopoietic cells. Although C7R CLL-1 CAR showed some benefit on anti-tumor activity in vivo assay, some mice from the group died earlier. So we have not known if this phenomenon is specific to CLL-1 CAR or specific to AML, because since the C7R GD2 CAR or C7R CD7 CAR did not have many toxicity in clinical trials, so I have not known the actual reason yet, but I want to figure these out. So this is my last slide. I'd like to thank to my lab member, which is pretty small, and my clinical member, and I'd like to thank to my US lab member, friends, and mentors. This project is supported by Japanese grant, Kakenhi, and we have been on Instagram, and I would appreciate if some of you or all of you will follow our account. Thank you very much.